This is very interesting. So today we're gonna talk about why and no when. And the reason is why is easier question to answer, why we go prone versus lateral. When is a little more complicated because the prone lateral access is one of the new tricks that we're doing. And as we do it more, as we learn, we will use it more or less. So right now, we don't know exactly where. I'm trying to push it in every type of different situation where I can do laterals. But I can tell you that it's not going to take over the lateral itself, but it's going to have a really good place. So I see it prone lateral as a complement of the lateral itself. And so that's why I'm going to tell you today why we use it versus lateral. And maybe next year we start more talking about when. That is even a little more complicated question. So when you look at the prone lateral surgery, it's a couple of advantages. Okay, that's gonna throw you first this slide a little bit on data, but then in the next one we go a little more on details. So there is advantages for the patient, for the surgeon, and for the health system. I will call it that way. And as we know, for example, in general, in average, in America, is $62 for cost of, actually it's a minute of OR cost, around $62. So if you can cut some time, obviously you're helping the healthcare system in terms of making it more affordable. So that's a really good proposition in terms of for the system to run. So you can do the same job and you can go from point A to B in less time. That's a really good alternative, okay? So then there is potential things like, yes, I mean, you can decrease hospital stay, but obviously, as you know, we as a surgeons, it depending how slick you do it, patients also are different. Some patients are easy to send home right away. Some patients just sundowning on that. But then for the surgeon, for us, it's very good to have access to the both columns right away. Obviously, you can make the argument when you do single position lateral, you also can do that. But to me, it looks like prone position is the most natural position for a spine surgeon to be there. We're very comfortable working with the patients on prone. You got automatic lordosis. You grew up, your first spine surgery was a prone surgery. And I don't know if anyone in here, his first surgery was a supine surgery. Probably the first surgery for all of us was what? A laminectomy, probably, yeah? So we are we feel very good, let's put it this way, working the patient in prone lateral. It's like we as a human beings, we feel more comfortable in the earth than in the water, in the shoulder in the water. We can swim and we can do a lot of things and we can stay there, but our natural habitat is just, messing around in the ground, not swimming, different than the fish, for example. So I would say for a surgeon, the natural habitat is probably, prone is a little more nicer, unless you're Neil Anand or John Ashgard. Those guys are phenomenal guys. They can do whatever, They're like, the Michael Jordans, they can play with right and left, Tiger Woods. So these guys, they're gifted, but we don't belong to that breed, yeah? So for us, normal people, I think that's one of the good advantages, be able to do things on the prone position, okay? So now let's go again a little bit and a little more details. To me, these are the 2, 4, 6, 7 really good advantages of prone position. And I'm going to go on each of these one, and then we get done with this talk. So one is positioning the patient. If you're doing laterals, on the lateral position, you know that the main thing is keep the patient orthogonal. You take a lot of time positioning the patient for a lateral surgery. Usually 60%, 70% of the surgery is actually getting the patient in perfect position on lateral. So when you do in prone, it's amazing. You put the patient right away on the table, as you saw John doing that corpectomy. The patient almost pretty much goes in perfect orthogonal position, and is a very stable position, yeah? So then, as Lenky always mentioned, you put the patient in prone, you get lordosis for free. I mean, right away, the patient gets lordosis. As long as you use like an OSI tables and you put the bolster where we should be, the lordosis come for free, which is huge for us, yeah? And then, obviously, the gravity is in our favor in some part of the surgery, like, for example, with the abdominal contents, obviously, everything tends to run anterior, which is good, so it's away from your dissection. And then, as we know, enabled technologies are taking over, so navigation, robotics, all that things, they work better also on the patient in prone, because the patient is more stable, we don't lose the references, it tends to work better, and obviously nothing easier to put a pedicle screw than in prone position. If someone in here tell me that you do better on the lateral, you are kind of the zebra of our surgeons, you know. So anyone in here think that putting a screw in lateral position is easier than prone? No one, yeah? Not even my two rock stars on the back. You know, they prefer, you guys prefer still prone, correct, Neil? And yeah, I don't know, Adam, everybody, I think everybody will prefer to put screws in prone.
Thomas, I don't know anybody who likes it.
Alex Thomas is the only one, you know. He's like, you know, but anyway, you know, he can keep fighting against the world. That's good. So
I still do them prone, but the robots are going to do them lateral for me.
Yeah. Okay. That's a good point, Adam. So yeah, when the robots are working the way that we want it, probably, you know, we're gonna be like pilots, you know, just sitting there in a monitoring mode, make sure that the computers and things do their job, and we're gonna get paid pennies. Sorry, guys, but it's not. All you guys are gonna be retired by then. So anyway, so and then. Is obviously posterior decompression is great, and it's a good time for savings. Okay, so let's go over each one of that. Okay, why we say easy positioning? You're looking here, we're doing a prone case. This is one of the first cases using here, MacGyvering, all these little things in here, trying to open this space. But as you see, prone is a really good way to put the patient orthogonal. You just drop it on the table, you just, you know, move it a little bit, the patient get perfect position. So it's one of the why we do it that. Okay, lordosis, using here. You take a little picture, prone patient, amazing, the lordosis. You put on the lateral supine, you need to start doing things different than normal, yeah? And then this is interesting because we were like, I was like, okay, so we're doing these prone laterals. Are we really making any difference in terms with measuring post-op and pre-op images compared to lateral? So actually we pull, you know, it's a small sample, it's not too many patients, and we, you know, we were able to make it published just to make people know that there is something here potentially. And we find, believe it or not, that when we do in prone laterals, actually we're getting a little more lordosis than we do in lateral. Obviously, as you see here, this is some examples, these two cases. Obviously, things changes, you know, how your posterior structures are, how your facets, how you loses your spine, where are you putting the cages. It's a lot of factors that can contaminate that, but it was very interesting that when we compare prone lateral versus lateral, actually we're getting a little more lordosis, you know, using the same implants, the same thing. So it's something that we had to keep at that. And then obviously using here, this is another study that we did in voluntary guys doing MRIs, and we put the MRIs on different positions, lateral, supine, and prone. And as you see that in prone, actually these retroperitoneal contents, they tend to move away from the approach. It's minor if you're looking here compared to supine or lateral, but definitely these few millimeters, few take a good toll in this. And then the next one is navigation. Using here and doing a case, and take a look how nice the navigation works in prone, you know. This patient is totally stable. You have everything on there. You're looking here, and on the screen of the navigation at the end, is a very straightforward way. You can pass your instruments, and navigation is becoming, I would say, a necessary tool on for the modern spine surgeon, you know. I would say, I can challenge you, but I say in 5 years from now, most of you guys will do in cases with navigation. How many of you guys are using navigation routinely all the time? Okay, so we have our 2 rock stars every day because these guys are ahead. How many of you guys are using navigation in here all the time? Okay, if I go in 1 year, I'm gonna have half of the room using it. And if we go in 5 years, everybody will be like 2 hands, you know? And why? Because one thing is you have a three-dimensional view of the spine, which is huge. You know, having the axial view of the spine is huge. Second, the radiation for you is less, so definitely. And third, the systems are getting better and better. So the more navigation system available, the more easy to use, the more we're gonna adopt it. So I would say that radiation that we get with fluoroscopy is little by little is gonna take away, you know, because we know that it's not good for you or for the patient, yeah? Then pedicle screw placement, I mean, there is no question, you know. When you're doing a pedicle screw placement, you know, in prone position is the way to go. You see how in here the navigation marks as good, you can work around it, you don't have nothing around. When you're doing these screws lateral, you're crazy, especially the lower screws. I mean, you're like working like that. It's like a very out of your mind. So that's another reason why we push in prone. And then obviously this is, we love this option because if you're trying to do a posterior decompression or open, actually you can have 2 surgeons working at the same time, or your PA or you can start doing the approach and do that, you know? So this is a unique advantage of the prone position. You can go very easily back and forth, both of them. And then obviously, as you see here, putting screws and dealing with a posterior elements is not a big deal. So then in summary, the advantages of being prone is which ones? Okay. Easier to manipulate, put screws, easy to position the patient, is friendly with the robotics, and it has some potential for time savings. What is the advantage on the other side when you do lateral? Obviously, when you work in lateral, the ergonomics are better. I don't know if you see some of that pictures doing prone. We extending the neck and we struggling. You know, we're trying to compensate that using cameras. And as John mentioned, he started ruling some rules. He said that he likes the bed. What did you like the bed, John? At the height of your
Mid-humerus to the shoulder and like 5 degrees of rotation.
So these are the things, for example, that you guys take advantage, so you don't need to break your neck when you're doing that. Also on the lateral, when it's very easy to break the table, so the distance between the iliac crest and the T12 rib is easier to control on the lateral position. The prone is way more complicated. It's more intuitive, you know. You go lateral, you put the patient on lateral, you know. If you go prone, you go prone. If you go supine, you go supine. Yeah. So the prone lateral is a little bit against the common sense, you know, because lateral should be lateral. However, we are giving away a little bit of that in order to have access to the prone part, which is the screws and that way you can have significant complications. And then another thing is when you're working in prone, get ready because you're gonna work deeper than normal. Lateral is way less deeper, so the less deeper you are, the easier to do your job. So then that's basically why we use in prone lateral. There is challenges, yeah, and these are the big challenges on adoption of prone lateral up to now. One is limited visualization, you know. So we're working with longer retractor blades. The fat tends to come more because you work into a longer corridor. The ergonomics is a little bit complicated. So that's the challenges. Doesn't mean that it's a no. It's just something that we had to work through it. Teaching, when we put the cameras, for example, the teaching becomes more obvious because obviously when you're doing prone, my fellows are like, listen, seriously, another prone, we can see anything. How are we going to learn this? So I think including the cameras is getting better. Navigation also is helping us because we see what they're doing. And then obviously, if we can, the modified or workflow, if we can start understanding what are the natural flow when we have the patient in prone lateral, then we can get that. But that's basically the reason why we're pushing from prone lateral. And as I told you is don't get in this game like, prone lateral, we take over lateral. Just use it as a complement. Sometimes you use it for some things, sometimes you use it for other things, and at the end, it's obviously dealer choice. You use what you think is good for your patient. So that's pretty much. Thanks very much, and questions will be more than open.
Hey, Juan.
Yes, sir.
So do you think people should start doing this first in a lateral position, then doing prone? What's your advice?
I believe so. Yeah, I think there is a process on this. I think obviously first you have to come, courses like these ones, mess around with the cadavers, make sure that you have to check box the anatomy part. You need to know where the lumbar plexus is, what are the fundamentals, do a couple of laterals itself, pre-transoas, you name it, but be familiar with the retroperitoneum, and then you jump into the prone. Yeah. John, you want to say something?
Yeah, no, I completely agree with that. I think your retractor time is, I'm a big believer in retractor time. So until you can get a reasonable retractor time on your lateral, you should be jumping into prone because you're just going to add on top of that. The second thing I was going to ask you is, you have a tremendous amount of experience with it both navigated and with fluoro. How do you engage that workflow? Sorry, how have you adopted fluoro, and when do you use it?
That's a really good point. And you see a lot of my pictures, you see still the fluoro hanging on there. So I'm doing a very smooth transition. I always say as a Colombian, we don't believe, not even in our mothers. So we are very, we don't trust anything. And navigation system, don't forget that you're relying on a CT that was before, and it's not a real-time information. So I take once in a while an x-rays, but I can tell you, the more I do the navigation, the more I trust it, the less shots I take on the fluoro, and I have a feeling that, and also the better the systems are getting. How much of your case is 100% navigation, John?
So none of my cases are 100% navigation, because the part I don't trust, and this is what Neil and I were talking about, I will still always trial.
The subsidence. Yeah.
Right, yeah. I will always trial under fluoro and implant under fluoro. But I think most of my shots oftentimes end up being when the retractor positioning everything in the right spot. Yeah. And that has essentially been eliminated. So I take 4 or 5 shots at the very end of the procedure, but I don't have to take many of those shots of localization shots that I have to, that I actually think predominate, and that's where we get most of our radiation exposure.
Yeah.
That's why I like it. It doesn't eliminate fluoro, and don't think of it as a replacement for fluoro, but it does safety it for everybody. And always, just like Juan says, having it in the operating room is important.
Yeah, and you have to be, that's a great point, and you have to be very careful with what we call enabling technology. You can have a really nasty complications. Actually, I'm collecting, through the friends and network that I have, series of complications, and I put a talk together. It's going to be when the enabled technologies become disabling, so you have to be careful. I mean, the thing that you see is crazy, so why? Because you cannot rely 100% on a piece of computer or something. You still need to use your surgical skills, and once in a while, as you say, define your flow, when the flow is good or not. Yeah.
Juan.
Yes, sir.
One other thing, you said when you were showing the start, you said you kind of put MacGyvered some things, and you're talking about putting like that contralateral post there so that when you're pushing against, you mentioned MacGyvering. And one thing I think that's slowing down the adoption or the ability to adopt prone lateral is buy-in from our industry partners. I feel like there's a small part of the industry that's saying, well, here, we're going to create everything to help you do this. And it took a long time for all the, at the beginning, it was just one company that was doing lateral, right? And then everyone else said, all right, well, here, there is a market share for it, so let's invest and make our own. And then they've done so. And I think that the industry is lagging behind in prone lateral in helping us to be able to adopt it and have the tools, and having not only the enabling technologies, but the enabling tools, the enabling posts and instruments. So
I'm gonna. That's a really good point, Adam. I'm gonna tell you exactly what you describing in the layman words is what's happening with the cars right now. The electric cars. There is one company is way ahead, and the other ones are trying to make it. They can do it, but it's still there. And then the engine combustion, they are the same. They kind of, you just get a little bit in here and there, but is the big difference is on the electric things. This is in here. The prone lateral is a little bit of different. That's what you're trying to say, John. Not John, Adam.
Yeah. I feel like there's this lag, and the question is going to be whether or not there's a market enough for it for everyone else to start investing in creating their own tools.
Yeah. And he's going to go through a process where you're going to have, remember the lateral when he started? There was a point, 2010, 2009, when they say that 4-5 lateral was a contraindication. And actually there's a paper, that paper by, what is the name of this woman? In New York, she put a paper saying that L4, L5 lateral should be a malpractice. Should be like a malpractice. Nancy Epstein, basically. That's her paper. You guys want to read it. There was like a 4-5 lateral, and today, 4-5 is like, you do it every day, So I think this prone lateral is going to go through that. Whoever doesn't have market share will fight it. Whoever has a market share will push it too much. So our job is make sure that we find the sweet spot, don't get too much contaminated by that, but definitely I agree with you, Adam. This is interesting, but I think lateral prone is going to go somewhere. Don't you think, Rod?
Yeah, I think that I think you guys are right, but I also think we learned so much doing lateral. I think going prone is taken to the next level.
Yeah.
And I do agree. I think it's, between the enabling technologies, the companies, I think there's it's really an exciting time for spine.
It is because it is amazing. We were thinking that, we'll be done. And as I always appreciate too much people like Luis Pimenta, Bill Taylor. Mm-hmm. Those guys are, no matter how old you get, those guys are always pushing. And you guys, most of you guys on the audience, you're the next generation of the spine. Don't guys feel hungry, feel uncomfortable. Don't get happy with the 3 things that you learn how to do it. You're in here today because you're trying to get new things, and that's the way that should be. Keep reinventing yourself. Remember Madonna, all these things. You think that people are just sitting and partying? That people work so hard. They're reinventing every day themselves.
They don't know who Madonna is.
They don't know, but what you think that, Neil?
They're too young for Madonna. Yeah,
I know, but they're reinventing themselves every day.
Thanks, Juan.
Okay, guys, thanks very much.